Hi, everyone. It's Maureen Aslan from Dying with Dignity. We're just going to give the technology here a couple of minutes to catch up. When we do these webinars, we need to allow time for people to join the meeting. So when I see that we are near our full level of people attending, I'll start the webinar. In the meantime, we'll just be on hold for a moment. And thank you. Hi, if people have just joined, we are allowing the technology to get everybody on board before we start the meeting. We'll give it another 30 seconds or so and make sure we have as many people joined on the webinar before we go into our presentation. But welcome everybody. It looks like we have a full complement of folks joining us today, and we're really pleased to have you here with us today on National Advanced Care Planning Day in Canada. And this is at a really poignant moment in light of COVID-19. And we're bringing you this special presentation today specifically on advanced care planning and in the context of COVID-19. So I think we have everybody who is on board now for the presentation, and we will begin. I want to welcome you to the End in Mind series of talks on death and dying from Dying with Dignity. In 2017, Dying with Dignity launched the End in Mind online education series. The purpose of these webinars is to engage Canadians on a broad range of issues related to death, dying, and planning for end of life. We hope that by participating in events like this one, you will come away informed, intrigued, and best of all, empowered. I just want to go through a couple of technology housekeeping issues here. Right now, everybody except the speakers is muted. We have the capacity for you to ask questions. You'll see an icon at the bottom of your screen in that black bar. It says Q&A for question and answer. If you click on that, the screen will open up and you'll be able to type in your question. You can do that at any point during the presentation, but there'll be a section about halfway through where I'll stop and give you instructions on how to do that. And then we'll take all the questions at the end of the slide presentation today. So the presentation will be about 40 minutes long. We'll start out with covering ACP, and things generally that apply to ACP, advanced care planning at any time, and then specific items to COVID-19 and the pandemic that we're living in right now. So without further ado, we'll go into the slide presentation. As I said earlier, my name is Maureen Aslan. I'm the Education Manager at Dying with Dignity Canada. We are the only we are the only end of life rights organization with human rights organization dealing with end of life in Canada. That took a while to get out, but that's what we are. We are been around for about 40 years. And this year will be our 40th year anniversary of the organization. Today, the presentation is Advanced Care Planning and COVID-19, Voicing Your Choice in Uncertain Times. We were founded in 1980, 40 years ago, as I said, and we're focusing on end-of-life rights and the quality of dying for all Canadians. Through our history, Dying with Dignity has led the way in helping people avoid unwanted suffering through advocacy, public education, and personal support. These are the principles on which we work: the 4 pillars: eligibility, access, support, and education. And it's important, I want to note right now, that all Canadian adults have the right to be fully informed of all treatment options in regard to their health care, to have our substitute decision makers recognized, to have our advanced directives. And I'm using advanced directive in a very broad term. I know that's called different things in different provinces, but here today, because it's a national webinar, I will be speaking in terms of advanced directive, and we'll talk a little bit more about what those specific terms are for each province. You also have the right to a second opinion. You have a right to have your pain and symptoms adequately managed. You have the right to refuse treatment. You also have the right to end your own life, and you have the right to choose a medically assisted death. So these are the rights of every capable adult in Canada. So joining me on the webinar today will be Connie Jorsvik, our National Advanced Care Planning Coordinator. Some of you have heard Connie speak before on advanced care planning. And just to let you know, Connie is an independent healthcare navigator and patient advocate with her business Patient Pathways in BC. She was a critical care nurse for most of her 25-year career. We also have as our special guest today, Valerie Cooper. Valerie is a hospice palliative care nurse practitioner with the Southeast LHIN in Ontario. She also lectures in the undergraduate program at Queen's School of Nursing and has developed and taught an elective course on hospice palliative care nursing for the past 4 years. Valerie is a member of the Dying with Dignity Canada's Clinician Advisory Council, as well as many communities of practice related to both palliative and end-of-life care and medical assistance in dying. So let me start out by talking about advanced care planning and just generally what it is. Advanced care planning is important for all adults, no matter your age or state of health. Anything can happen to you at any time. So it's really important that as a general practice, advanced care planning is something that we're doing regularly and that we take responsibility for. The COVID-19 pandemic heightens the need and the urgency with which we should all complete our own advanced care plan. It's your life, it's your choice, but you need to clearly communicate your choices to your future decision makers and healthcare teams. So it's incumbent on all of us to talk to the people who may be in a place where they are speaking on our behalf. If you lose your capacity to make decisions for yourself or speak to your practitioner, your loved ones, your friends, the people you've chosen to speak to for you really need to have accurate information about what you want and to know you well and know what your values are. It can be difficult to predict what would happen if you got the coronavirus, especially if you're older, frail, or have multiple medical conditions. Many patients get mild cases, and we would certainly hope that you would be one of them. But if you could get very sick very quickly, and it's important to prepare for that possibility. This is also about talking to our loved ones about what they want at the end of their lives. Take the initiative to get this conversation started. Say to your mom, dad, wife, husband, best friend, anyone who you're close to and might have a conversation with, what things are most important to you if you were in the last stage of your life. What steps do you and those you love have to take in order to ensure those needs are met? Doctors everywhere are concerned about providing care that is not aligned with their patient's goal. So no physician wants to do something that is not meeting their patient's wishes. Because of this urgent call to action, we will be frank and direct. We will be giving you homework and information you can use right away. I just want to make a note that this might become overwhelming, this presentation. I know the impact of the pandemic on me and my family. Everybody's a little anxious. We're not quite sure what to do. We're kind of settling into a new normal. and emotions tend to be fairly high, and this is a very content thick presentation. So first of all, I want to let you know that it is being recorded. You can come back and watch it anytime and can find it on our website under past webinars. And certainly if you need to step away during the presentation today, please do. The recording will be available. You can come back and go over it at your own pace, and you can watch it as many times as you'd like. Also, I want to let you know that we have a set of notes that will be the slides and other notes that relate to the material. And that will be sent out to you after the webinar, as well as some other resources. So everybody who is signed on today will receive those items via email early next week. So the statistics from the Government of Canada website as of April 10th are that only 6% of COVID-19 cases need hospital care, and only 1% are fatal. While this is hitting people of all ages hard, those aged 40 to 60 have the highest hospitalization rates. Most of those dying are the frail and elderly. Advanced care planning is important for every adult, but during the COVID-19 pandemic, it should be a critical call to action for many. For those over 50 years of age, the older you are, the more important it is. Those who have multiple medical issues, which are called comorbidities, and these are the issues to pay particular attention to if you have heart disease of any type, including high blood pressure, chronic lung disease, diabetes, or if you're immunocompromised for any reason, which would be taking medications or systemic therapies for any disease, including cancer. I will now hand over the presentation to Connie.
Thanks so much, Maureen. I've been noticing a couple comments coming in about our internet connections. Unfortunately, the entire system is really overloaded these days with everybody watching Netflix and doing work from home. So we apologize in advance. It's beyond our control. And if things get too glitchy, we'll try and deal with that. So welcome everybody, and thank you so much for attending today. I've been on board as the National Advanced Care Planning Coordinator since last August. And my mandate was to upgrade the advanced care planning toolkits across the country. And we're so close to getting the British Columbia toolkit out to for final review legally and to clinicians. And then along came COVID. Today was supposed to be our launch for the new toolkits. And due to a number of reasons, and this is certainly one of them, we haven't done that, but we're so pleased that on Advanced Care Planning Day, we're able to do this with you. So advanced care planning always seems too early until it's too late. Because of the COVID-19 pandemic, people are finally talking about a topic that they want to avoid. It's no longer too early. I'm going to read you a Dr. Seuss poem written by Tim, I can't remember, Tim Boone, who's an RN in the United States. He's a palliative care nurse. And I'm going to read various parts of of it to you today. It's a very long poem, and when we send everything out to you, we're going to send you out the entire transcript. I'm writing this poem to help you discern the actions to take and the things to refuse when some terrible day you are faced with the news that some sudden illness or stroke of bad luck has left me unconscious and helpless and stuck. Face up in the ER, laid out on a stretcher, with chaos around, and you're under pressure to make some very quick, high-stake decisions. I want you to feel at least you have a vision of what you can do, so you know in your soul that you've done what you can within your control. So what he was talking about is advanced care planning, which is an umbrella term for conversations and documentations about your values, beliefs, and preferences for future care in a time when you can't make those decisions. We've broken down the umbrella of documentations and conversations into an umbrella, and first and foremost is values and beliefs. We also have ongoing discussions, health documents, financial preparation, and estate planning. The vital first step is to think about your values, beliefs, and preferences for future healthcare. Think about the context of where you are in your health journey, and we're going to go over what health journey means. Think about what's important in your life now and in the future, and in case of serious illness, injury, illness, and end of life. So we're talking about COVID-19 today just because it's on everybody's minds, but this is something that should be going on for everybody at all ages and all stages of life, because there are still car accidents happening. We're still coming down with cancer. We're still having heart disease. This is just a little bit of a spur to get things moving. Ongoing conversations. It's important to have frank conversations with your loved ones, substitute decision makers, and a healthcare team. Starting these conversations may lead to deeper conversations over time. We know that this part is really tough. Important health documentation includes medical history and in case of emergency documentation. We are about to launch an fillable in case of emergency form that will go up on the website, and we'll be letting everybody know about that. And it's something to add to your advanced care planning documents. Want you to choose your substitute decision makers, and we'll be going over what that means, and write a formal advance directive clearly stating your wishes for health. As Maureen alluded to, advance directive is the general term that's being used across the world. Healthcare legislation is 20 to 30 years old, and so it hasn't caught up in some of this terminology, but that's what we're using. And the Canadian Medical Association and the Nurses Associations and Speak Up, we're all trying to use the term advance directive. We want you to leave a legacy and not a mess. This is an important opportunity to review and put in place your paperwork for advanced care planning, financial preparation, and estate planning. Financial planners, notaries, and lawyers are still all working, although like the rest of us, remotely via telephone or teleconference. The number of requests for wills has gone up dramatically over the last couple of months, last month in particular. So a lot of people are getting on this bandwagon, and it's good to see. So a little bit about financial preparation. We have a similar cat. Valerie and I have the same cat. Keeps on insisting on going across and being part of the presentation. As all of you have noticed, this working from home stuff is it's quite interesting. Get and keep your financial documents in order. So I've actually pulled all of my documents out and I've put them in a very in a place that's getting in my way, and so that I can get it done. And I'm taking little bits out of it all the time, getting rid of documents I don't need anymore. I'm trying to walk my own talk on this one. Get a power of attorney for a financial agreement together. Notaries are apparently doing, are coming and are personal distancing or physical distancing and witnessing for people when they need those done. Liquid assets to pay for unforeseen costs of loss of income, medical equipment, and private home care and private residential care. We can go ahead. I just wanted to make a note about mental capability. Advanced care planning documentation is done. It can be, advanced care planning documentation is done in preparation for a time when you are no longer capable of making your own healthcare decisions. During COVID-19, this is extremely relevant. With COVID-19, the progression of illness can be sudden, and even prior to ventilation, you may be so ill that you can't make decisions and will need to rely on others. If you are on a ventilator, you will likely be deeply sedated and others will need to make decisions for you. Which brings up changing or canceling your advanced care plan. When you're capable, you can change or cancel, which means revoke any of your advanced care planning documents at any time. I advise that if you have an advance directive in particular that a lawyer is doing up for you, that it's separate from the rest of your advanced care planning documents, so that you can change it as time goes by, and that it doesn't have to be pulled apart from your other documents. If your directive is specifically in preparation for COVID-19 and it is different than it would be in other circumstances, consider revoking and rewriting your directive after this crisis has passed. Just going to have a sip of water and then we're going to get started. Strategies to assist you in completing your advanced care planning. Prioritize what needs to be done first. If something unexpected happened tomorrow, like COVID-19, what would you wish you would have done? What are your biggest risks? Do this part of your advanced care planning first. So you might want to have conversations with your loved ones right away. That's certainly high on the priority list. Even if you don't get your advance directive document written, at least somebody knows, the people who know you will be able to speak for you. And the other piece is a lot of your paperwork that should be done. So I reviewed my advance directive. Here comes the cat again. Somebody's always got to be part of the show. If you've had an advance directive in the past, if you have a substitute decision maker in place, you might just want to review those documents and then move on to your advance directive. So what you need to possibly help yourself get this done. Prioritize what needs to be done first. Set up a buddy system. Set goals, dates, and mutual accountability. Excuse me while I just get rid of a cat. He's distracting me. Put it into bite-sized pieces. Break advanced care planning into realistic tasks, knowing that time is of the essence right now. And then reward yourself, something to mark that you've met this goal. So maybe you could go to your almost closed coffee shop and buy yourself a special latte to go. The steps in advanced care planning. Choose your substitute decision makers. Determine where you are in your health journey, which is a vital step with COVID-19. Consider your values and beliefs. Talk with your substitute decision makers and loved ones, and document your wishes. So choose your substitute decision maker. This is often a piece that people don't do. And we're going to go over the reasons that it's really important. Substitute decision maker is the accepted worldwide term for the person who will make healthcare decisions for you when you are not capable of making these decisions for yourself. We've put together the formal term for a substitute decision maker by province. If you've got a notepad handy, you might want to find your province and the term that is used for your substitute decision maker. I'll just let that stand for just a moment. And while you're doing that, the Canadian Hospice and Palliative Care Association is really pushing that there is cross-country legislation, changes to legislation, so that these kinds of terms, then documentation is more consistent across the country, and we're certainly behind them in doing that. Okay. In all provinces except British Columbia, your substitute decision maker is named on your directive. In BC, your substitute decision maker is formally and legally named on a representation agreement. We won't be going over representation agreements specifically today, other than that is a separate document from your advance directive, and we will be having British Columbia specific webinars coming up shortly. So here's the part that's really important when you don't have a temporary substitute decision maker, or you don't have a substitute decision maker that you have assigned. There's a temporary substitute decision maker hierarchy in every province. If you are not able to make decisions on your own behalf, and if you have not assigned a substitute decision maker, a temporary substitute decision maker will be authorized to make decisions for you. They are determined by your relationship to you and where they rank in this hierarchy. The hierarchy varies slightly across the country, but generally a spouse is first and adult children second. In most provinces, all individuals included in a group carry the same weight. Example, 3 children must all come into an agreement about healthcare decisions, and no one child has more to say than the other. I'm going to have Valerie step into this in just a second, but I have one specific, I've had one thing come up several times in my practice where the wife was automatically considered the substitute decision maker for her husband. And in several cases, the wife was also heading in her own dementia journey. And so the healthcare professionals were talking to her. None of these women could remember what was being told. And because a representation agreement or a substitute decision maker hadn't been put in, the healthcare authority was under no obligation to talk to the children. And it made communication extremely difficult. So Valerie, could you weigh in on the adult children issue?
Yeah, and I think one point I want to make in regards to the COVID-19 situation, especially for those of you who thought about some of the criteria or notable circumstances around your health that apply to both you and your spouse, or you and your substitute decision maker, whomever that might be, is to make sure that we're choosing a substitute decision maker who is likely going to be around and available to make decisions on your behalf. So if your substitute decision maker is your frail elderly husband, he may not be the most logical or the most robust person to hold that role on your behalf, because he very well might come down with this as well. In regards to the hierarchy of substitute decision makers, which applies in most provinces, and I live in Ontario, so I know Ontario best, but we often use the example of, there are, let's say, 4 children instead of 3, where in order to come to a consensus, there would need to be, everybody would need to be on the same page, or 3 out of the 4 children. That may not be the best situation to leave your kids in, and it's probably better to either choose one of those children if you don't think that that's going to cause issues within your family, or someone a little bit more distant outside of the family who is sort of can step away from an emotional perspective and make those really difficult decisions. And Connie's going to speak to that on the next slide, but I think it's really important that I think this step in determining who your substitute decision maker is really probably the most important decision you can make, because that's the person who's going to be speaking on your behalf. I just want to note, I did quickly read some of the questions that have come through. Anything that's provincially specific, at the end of the toolkit, which will, some of you may have read already, but will be sent out in the email with the notes from this presentation, we'll have the specifics for each province. So I noted that Quebec was missing from our list, shame on us, and Nunavut. So if there are specifics around provincial questions, then I'd refer you to the resources at the end of the toolkit. But Connie, if you want to continue.
I just want to address Quebec and Nunavut. under healthcare legislation, none of it is considered a Northwest Territory. And they fall under the same healthcare legislation. That's why they're not on there. And Quebec's healthcare is so vastly different than ours that they will take an entire different advanced care planning toolkit. And so that's why we didn't include them in this one. Anything to say on that one, Maureen?
No, just that that we'll be looking at the possibility of having a Quebec toolkit in the future, but right now we're not able to provide one. We hope to soon. Thanks.
Okay, so a few things to consider when you're choosing your substitute decision maker. We can just pop ahead 2 slides. They can't be paid to care for you except a spouse or adult child. So you can actually put aside money to help an adult child look after you, and they can still be your substitute decision maker. They must be mentally capable and an adult, and that age varies. In a couple of provinces, it's 16 years old, and that is, in my perspective, a little bit too young to be a substitute decision maker, but that's what it is. And the most important part is that they are readily available even by phone. During COVID-19, chances are that they won't be able to come and visit anyway. So if you are in Vancouver and your loved one is in Toronto, that's going to be just fine as long as they're readily available. A big piece is that they're ready and willing to take on this role. Quite often we just assume that somebody will step in and do this for us. But not everybody is up to the very difficult decisions that need to be made. They will respect your religious or spiritual beliefs. And a really huge one is that they will carry out your wishes even if they are different from your own, and thus create difficult choices. Valerie, do you want to step in on that one?
Yeah, I think in working in the ICU setting as an RN, I had lots of exposure to situations in which people were making really difficult choices for their family members, and it's almost impossible for someone to make a difficult choice when they haven't had an opportunity to have a conversation with the individual who they're making that choice on their behalf. And so if you think that the first step is to have these conversations and to share your wishes, but if you feel that the individual who is by default your substitute decision maker, or who you initially thought would be the person who you would choose, would have a really difficult time abiding by those wishes. So for example, you may value quality of life over quantity of life. And if you weren't able to do X, Y, and Z, you wouldn't want to be put on a ventilator, but you recognize that this other person would value quantity of life with you over your quality of life, and would have a really hard time making that choice, knowing that they would be shortening the length of your life and therefore their life with you. It may be better to explain to them, I really appreciate that the choices that you might have to make may be really difficult for you, and I want to save you that additional stress in an already really stressful time. And I think it would be easier if so-and-so were able to make these choices for me, knowing that these are the choices that in fact I've dictated for them to make.
Okay. Your substitute decision maker is often a close relative. Statistics show that it's usually a daughter or a daughter-in-law, but you can also choose a close friend or neighbor. So I've had several instances where a neighbor was closer and was able to act as the hub of communication to the rest of the loved ones. And I've certainly acted in that capacity as well. It doesn't mean that they're going to make all the decisions, but they end up being the spokesperson for the family, and that can take a lot of pressure off. And if that person is maybe not quite as emotionally connected, they can make more logical decisions. Valerie, any more to say on that?
No, I agree. That's
okay. Talk with your substitute decision makers and loved ones. Share your values, beliefs, and preferences for future healthcare, and don't assume they will know what you want. Family members are often wrong about what the care that their loved one would want and when treatments would be discontinued. It's particularly true for husbands and wives. They rarely have the conversation. They only have a conversation 30% of the time. And they would often make a decision on their own choices for what they would want for you rather than for you yourself. So be very clear. If your spouse is going to be your substitute decision maker, it's one of the most important conversations to have with them, is specifically what you want. Have these vital discussions now, prior to the possibility of contracting an illness. Your loved one and decision makers need to know your wishes in order to assertively speak for you. And I'm going to give you another part of the Dr. Seuss poem. If it's day 2 or day 3 and there been no real changes, if we've not gotten past keeping vitals in ranges, that keeps me alive and organs transfused, and my mental state's worse than just plain confused, and I'm not able to talk or think or write, it's time to get serious about how long to fight. Now is when you have to deal with the odds and the chances and get all the intel on my circumstances. Make sure all the docs are real honest with you and they've given a total and thorough review to help make it clear what you think I would do. If there's a good chance I'll emerge from this coma with nothing so bad but a limp or a stoma, then tell them to go ahead with their bad selves and flitter around me like magical elves and poke me and prod me and turn me about and shove in more tubes from my tail to my snout. So this is an example of this isn't an all or none. You can have everything done, and after a thorough evaluation, just be clear with your substitute decision makers what you want to see. And I personally have seen, and I'm sure Valerie has too, is that you don't know what you don't know about your future, that we don't have crystal balls. And it's really important that your substitute decision makers are getting the information from the healthcare professionals. But then they could say, this is what mom would want, or this is not what dad would want, and to be able to move forward. Anything else on that, Valerie?
No.
Okay. So we want you to determine your values and beliefs. And what the heck are values and beliefs? In this webinar, our focus on values and beliefs is a shorter exercise focused on a time of crisis. Here are a few simple questions for right now. What makes life worth living? Is it being quality time with your family? Is it being able to get out in your garden? Is it being able to feel the sunshine on your face? Those are important values. What can and cannot be sacrificed or compromised? What needs to be completed before death? What is unacceptable to you? I'd rather die in comfort than, and consider any special faith-based or cultural preferences. So under the what's unacceptable to you, another example would be I'd rather die at home or in a care facility than in ICU alone. And that's a really big concern right now for a lot of people. Valerie, you step in.
I think thinking more along the lines of the example I gave on, quality of life versus quantity of life, and what brings quality to your life. Is independence absolutely paramount? And if you had to rely on anybody for your activities of daily living, getting dressed, showering, self-care, that sort of thing, would that be an acceptable life for you to live? And right now, in the face of COVID, as Connie alluded to, the realities are that people are dying alone, completely alone, with just the healthcare providers there in their last moments of life because of visiting restrictions and personal protective equipment shortages. And so for some people, it may be a real turning point to decide, you know what, I would rather die sooner at home with my family present than to perhaps get a few more days or a few more weeks of life, but then to die alone in an ICU. So things to think about.
If you were to acquire this and survive this infection, what would you want your life to look like as you recover? What do you value? How do you feel about quality of life versus quantity? And where would you want to spend the last hours or days of your life? These are difficult things to think about. We encourage you to journal some of this and then begin to have those discussions. But it's also very important to find out where you are in your healthcare journey. Now more than ever, consider your values and beliefs in a realistic context of where you are in your health journey. If you became seriously ill and require treatment, ask the following. And this applies to all illnesses, injury and illness. It doesn't matter whether you're having a CT scan for something totally unrelated to COVID-19. Doesn't matter if you're having the most minor surgeries. This is a really good list to have with you and to ask point blank about. The benefits of treatments, risks and burdens of treatments, short-term and long-term outcomes, alternative interventions and treatments, course of the disease if there's no intervention, and comfort and palliative focused interventions, and base all of those decisions on your values and beliefs.
So I think one of the things to understand is that these points are not only needed to be understood by you if you're capable of making decisions for yourself, but they'll also be the things that your substitute decision maker will need to understand. And I think sometimes it's hard for people to understand how discussing or determining what you value and believe is helpful in determining what medical interventions you would want. But speaking as a healthcare provider, you know, when I hear a family member tell me, well, mom really loved to share stories and to talk with her family. And if she's not going to be able to do that, her memory is going to be affected, or, you know, she's had a stroke and there's a likelihood that she won't be able to talk and share with her family the stories that she loved to do before, that may impact whether we move forward with sort of more aggressive life-saving interventions because of that value that family's sharing with me. So I think that's an important point to understand, that, you know, we're not expecting everybody to be medical experts and to understand the nuances of all of the treatments. But if you can share with us as your healthcare team the things that you or your loved one values and the beliefs that they have and the things that really are pillars within their life, that helps us to be able to frame our suggestions or treatment options in a way in that frame, as opposed to them just being medical interventions.
So, which brings up the point that we brought up multiple times, and hope that you're starting to see a pattern here, is that it's really important to talk to your loved ones and substitute decision makers. We understand that these conversations aren't easy. Try and keep it simple, direct, and specific. I've had several people who I've helped them write out a script of the things that they want to see, and they wrote it as a letter. And they actually read it out loud to their loved ones. They found that they could keep control of their emotions while they were reading the letter. And they told their family how vital and important it was that they have that conversation with them. And just know that this may be the greatest gift you can give those you love the most. So we're about to launch into actually writing your advanced directive. If you have any questions about the general subject of advanced care planning, substitute decision makers, and values and beliefs, and you've not already submitted them, please submit them now. We will be compiling them and answering them shortly. Please take a moment to stand and grab a drink of water, and we will be back just within moments.
Thank you, Connie. And while we take a bit of a break here, I'll just remind people that if they have questions, they can go to the Q&A button on the bottom of their screen on that black bar. We have some questions queued up already, so you can add your question into the lineup. We'll have a bit of time at the end. I also want to note that if your question is specific to MAID, we may not get to it. We'll try and do our best generally, but we'll, and if it's a very specific question about your situation, we'll certainly have a record of all the questions that you asked. We'll get back to you after the webinar if we aren't able to answer it within this forum. I know we have so much information we're trying to get through, and we'll do our best to get to the questions, but please know that we'll come back to you and make sure that you get an answer. So I welcome people to come back and rejoin us here, and Valerie can tell us more about advanced directives.
Okay, so we're going to get into a little bit more specifics around an advanced directive, and I noticed one of the questions earlier on was around Ontario terminology, and you're right, in Ontario, and we'll speak to this specifically in another slide, we don't really use the term advanced directive as a document. We use it sort of more to part of the conversation of advanced care planning, so this still is applicable to us Ontarians. And as we've said multiple times, having this conversation with your loved ones and substitute decision makers is really the most valuable and important part of advanced care planning. So even if you don't have an opportunity to document or to complete a formal form or the formal document applicable in your province, having this conversation, it is still really valuable, and it shouldn't dissuade you from entering into this work if you can't complete the full document, because the conversation really is the most important. That being said, if during this pandemic you don't have a substitute decision maker that you've identified, or they may not be immediately available to speak to a healthcare team, your directive should really be as clear and detailed as possible. Within your advanced directive, your healthcare team needs to know who is going to speak for you if you no longer have the capacity to speak for yourself. And remember, a substitute decision maker only speaks and only makes decisions for you when you are no longer capable. And so an advanced directive would only come into play if you were no longer capable. Your team would want to know any specific medical treatments that you do or you don't want, such as cardiopulmonary resuscitation or CPR, intubation, and ventilation. It should also document your values and beliefs so that they can sort of help interpret what that means in a medical context or for the interventions they're suggesting. And ideally that it's signed and witnessed and dated. One thing to note right now in this situation is that some of the acceptability of advanced directives being formally witnessed may be sort of looked over in this case, knowing that circumstances are different and it's hard to get documents witnessed either virtually or being accessible to those individuals who do the witnessing. So again, going through the process and completing everything up until it's witnessed is still a worthwhile exercise. So the next slide just shows what the term for your advanced directive by province is. And this was another question that came up in regards to substitute decision makers in Ontario. The formal term for the document to identify a substitute decision maker is the power of attorney for personal care. So that is our Ontario specific document. So again, just adding to the Ontario specificity, as I said, it's not an advanced directive isn't a legal document. You may choose to write down your wishes, but really that's going to be used as a reference by your substitute decision maker in order to ensure that the healthcare team understands your values and wishes. They aren't consent, and I think that's the important part to note in Ontario, that your wishes and either written down or expressed verbally do not imply consent, and that the healthcare team still needs to have an actual conversation explaining the risks and benefits of any treatment intervention that's being proposed with you or with your substitute decision maker, and then needs to get informed consent from them. Ladies, did you want to add anything else in regards to the other provinces?
I do actually. Hot off the press this morning, I got a response from Vancouver Coastal Health regarding unwitnessed requests, advanced directives. So I'm just going to read it out. With NBC, there's not been a statement either allowing or prohibiting virtual witnessing for advanced directives. If a patient did want to pursue this effort, then they would have to have a conversation with the patient, or the patient had with their lawyer. And I know that most people don't have lawyers. So, but if you do have an estate planning lawyer, you could probably talk to them about virtually signing a document. Vancouver Coastal Health would do their utmost to ensure that staff were able to assist with personal devices wherever possible. The advanced care plan, which for some reason Vancouver Coastal Health in particular calls a letter of wishes, is also an option, but it's not a legal document, and therefore the implications of not adhering to the documents would differ. And so it would be basically the conversations with substitute decision makers and the physicians. Within Vancouver Coastal Health, there's been a significant effort and emphasis placed on the serious illness conversation during this pandemic. The thought behind it is to ensure that patients that do not have official documentation about their treatment wishes, and these conversations between the most responsible provider and the patient will inform how the care ought to be carried out. So again, keeps on going back to the substitute decision makers and the conversations that you've had with your loved ones.
I'll just jump in and step back to Ontario a little bit. The advance directive is not a legal document. The wishes that you write in a very legal sense are binding. But I think Valerie addressed the issue in that the practice and what is practically going to happen when you're in a care situation is that nobody's going to be looking for that document unless you have it with you, and the physicians or treating healthcare providers will look for consent from a substitute decision maker at that time of treatment. So the difference between what the law is and then what happens practically in practice.
Good. So thanks, ladies, for that input. So the next slide basically provides the overarching message that the substitute decision maker discussions and decisions take precedence over advance directives. But the point of the advance directive is to support your substitute decision maker in making those decisions. Who can write an advance directive? You can. Everybody who's watching on this webinar and all of your family and friends, they're all able to write their own advance directive and to have these conversations. Again, I would refer you to your specific provincial and territorial documents in regards to what the legal requirements and witnessing requirements are. But as Connie shared, some of those things may not necessarily be as applicable in this setting. So many of you may have heard, in addition to advance directives or wishes for care, something called medical levels of care orders. And they're usually orders signed by a doctor or nurse practitioner, usually in a hospital or in a long-term care setting. And they're written after consulting with you or with your substitute decision maker about the level of resuscitation that you would want to receive. In most provinces, these are called goals of care conversations or goals of care orders, except in BC, except for in the Providence Health Authority, they're called MOST, or medical orders for scope of treatment. And I would suggest that most provinces and territories have, and even individual hospitals have different names for basically what these documents or orders are. The discussions and decisions for your advance directive are made prior to a crisis, and the medical orders that are often written to support the discussions that you've had in writing your advance directive are written during a hospitalization and crisis. So you can see how the medical orders should support, the advance directive should support the medical orders that are being written by your healthcare team. They shouldn't be completely disparate. They should be based on one another. I'll just speak specifically about Maureen's going to speak specifically about advanced directives and MAID.
Okay, just a special note about advanced directives and medical assistance in dying, which the short form, of course, is MAID. Advanced directives are only enacted when you are no longer capable of making your own health care decisions. So you've lost capacity, you're unconscious, you have a fever, you're no longer able to make your own decisions and communicate those. However, for medical assistance in dying, you must be capable at the time it is administered. That's under the law right now. So therefore, a request for MAID in your advance directive cannot be honored. People have written them in, but it is not the place to have it, and it will not be honored at this time. When advance requests for MAID become a legal option, we're hoping that they will, and that's something that we are pushing for in the future legislation. They will remain a separate document from your advance directive. So it's really important to know that when MAID becomes a legal option, it will be in a separate, and asking for it in advance for a time when you don't have capacity, it will be a separate document from your advance directive. And I'll leave it at that, and we'll answer questions in the Q&A.
Thanks, Maureen. So some notes about respiratory support and COVID, and we're going to speak specifically about ventilation today because we're talking about COVID. We also discussed within the toolkit some other specific terms and definitions that you may want to consider or understand a little bit more about to include in your advance directive. So we know that patients with COVID-19 are at risk of developing what's called sudden acute respiratory syndrome coronavirus 2, which is basically respiratory failure along with critically low oxygen levels. And these low oxygen levels affect all the organs in an individual's body. So best practice currently is to provide respiratory support with high flow oxygen. And this oxygen can be given in a variety of ways. And just to point out, like all procedures, we really need to look at the risks and benefits as was outlined in that list of things to consider when you're offered an intervention as to whether this is going to be appropriate for you and your health situation. So non-invasive respiratory support is providing breathing and that high flow oxygen for acute respiratory failure using a mask, so either over the nose or over the nose and mouth, or similar device without a tube being put down the throat, so it's non-invasive. Right now during COVID-19, we're trying to reduce the amount of non-invasive respiratory support that we're providing because we know that this can be an aerosol generating procedure, meaning that the virus becomes carried within the air in very small particles. So they're really trying not to utilize this in COVID-19 patients specifically, but it is an option at other times for respiratory failure. A ventilator is a machine that provides breathing support and oxygen, high flow oxygen through a tube down a throat, so an endotracheal tube, or through a tracheostomy, which is a surgical incision at the base of the throat that goes into the breathing tube down into the lungs. Sometimes a ventilator is used short-term during an acute event or during surgery and immediately afterwards, but it can also be used long-term as well. We know that patients with COVID-19 are spending longer periods of time on a ventilator if required than a typical pneumonia. And this is something important to consider because of the potential side effects of being on a ventilator. We know that 40 to 50% of patients with COVID are successfully being weaned from ventilators. So half or so of patients who require ventilation are being weaned, as we call it, or coming off of the ventilators. But as I said, it can be required for several weeks, and this can lead to complications such as organ failure and muscle conditioning or deconditioning, excuse me, that can be fatal. And if nothing else, will result in long-term rehabilitation requirements. So it's important to consider that, you know, going into the ICU or being hospitalized and requiring ventilatory support doesn't mean just, you know, a week or so on a ventilator. It means likely weeks to month-long hospitalizations and or, you know, weeks to month-long rehabilitation stay in a rehab institution. So it's not just that acute period of time that we need to consider. And there's data coming out that indicates that there can be some permanent lung damage that may be very significant. So in an individual who has an underlying lung condition, this may very well impact your decision to accept ventilation support. So I'll make a note here about medical assistance in dying, and I saw that it did come up in a couple of questions specifically related to COVID-19. So I'm a member of the Canadian Association of MAID Assessors and Providers, and we've been discussing this situation in our forum among assessors and providers across the country. And sort of our overarching consensus has been that because of the rapid progression of COVID-19, the likelihood of being able to sign a witness request and undergo 2 separate assessments while maintaining capacity is very low. With respiratory, severe respiratory disease, patients can become very confused if they have low oxygen levels. Their work of breathing becomes really difficult. So the ability to maintain capacity is very unlikely. And so our suggestion is that palliative sedation is the more reasonable option for patients who are actively dying of COVID-19. Now, that's not to say that we wouldn't assess and provide MAID for a patient who had COVID-19, but we need to keep those things take those things into consideration. So I think it's something important for, especially this audience with Dying with Dignity Canada, to be aware of, that you know, that may have been the way that you thought your life might end, but that might not be applicable in a circumstance in which you become diagnosed with COVID-19. So when you write your advanced care directive, we'd like you to think about the level of care that you'd want to receive. And the following information and examples for each of the levels of intervention can be found in the Advanced Care Planning Toolkit specific to COVID-19 that as we said, will be sent out in a link, but is also available on the Dying with Dignity website. There are 5 different levels or options from most intensive to least intensive. And the focus at each level is to consider where you are in your health journey and on your values and beliefs. And then using this guide and talking with your loved ones and substitute decision makers. Sorry, Maureen, I skipped ahead a bunch of slides, just trying to make up some time. I'm just on 88. And again, and again. So the level 1 is the highest level of care, and that basically means performing all resuscitation, including cardiopulmonary resuscitation. And this really is for cardiopulmonary resuscitation would include things like chest compressions, intubation, and ventilation, which I had wanted to point out earlier is life support, right? So being on a ventilator is what life support is. When we talk about, when you see on movies or TV shows and someone's on life support, that means they're on a ventilator. That's what that implies. So first level of intervention here, accepting cardiopulmonary resuscitation means you would be okay with chest compressions. You would be okay with having a tube down your throat and being attached to a machine that's breathing for you. And you would be okay with someone shocking your chest to reset your heart rhythm should it be in a shockable rhythm. It means you will go to ICU and you will likely have some additional complications resulting from these interventions, but that for an individual who might choose this level of care is someone who's relatively healthy at baseline and so could probably make a very respectable recovery and return to very close to the level of functioning that they enjoy today. So everything will be done to save your life at this level of care. Level 2 would be to not perform CPR, but to allow for other forms of resuscitation and transfer to critical care. So within CPR or sort of life-saving intervention, CPR is one aspect of that, but so are intubation and defibrillation. So you can make the decision or suggestion that you wouldn't want to accept, for instance, cardiopulmonary resuscitation or defibrillation, which are both specific interventions that deal with your heart, but you would accept intubation, meaning that you would accept a breathing tube down your throat and attaching to a ventilator, and you would accept admission to the ICU. This again is likely for somebody who has a fairly high level of functioning and very few healthcare concerns at this point, and who would be likely to make a reasonable recovery after these interventions. Oh, there's my point about the life support. Ventilator is life support. I knew it was in there somewhere.
There we go.
So level 3 is medical care without transfer to critical care. So no CPR and no resuscitation. But it does include symptom management, and it may involve transport to hospital for higher levels of care, minus the sort of intensive care level of things. And I think one of the things that, you know, if you're having these conversations with your substitute decision maker and you're looking to choose something in which certain interventions are not included, or you would not want them to be done, is to highlight with your family the things that you do want done. That it's not a let's not do this, it's a but let's do these things, and focus more on the positives rather than the negative side of things. So in this situation, we would still be doing symptom management, and we might consider transferring to the hospital if required. So likely this is an appropriate level to consider if you have some health issues yourself, or are, you know, low down on the frailty scale, because it's more conservative treatment. And so, you know, you're not going to undergo some intensive interventions that would definitely make an impact on your health, but you're willing to try some things, and definitely want symptom management. The 4th level would be that for those who are approaching or near the end of life and don't want any form of CPR or resuscitation, really looking for symptom management and supportive care. And so this would be appropriate for people with multiple health issues who are quite frail and who are nearing the end of life. And so those individuals who may be in residential care, long-term care, or nursing homes, or who are currently receiving care with a palliative intent. The goal being symptom-directed treatment, and it may allow certain medications like antibiotics to be administered if the goal of the administration was for symptom management. The final level would be level 5, and this is really, you know, symptom management. This individual doesn't want any prolongation of life whatsoever, and definitely no resuscitation. And likely this would be appropriate for individuals who are, you know, end-stage dementia or very close to the end of their life at this point anyway, and recognizing that certain interventions or most interventions are not going to change the outcome, and that this person is likely going to die in the very near future. So I'm going to turn it back to Connie so she can go through in review the checklist for advanced care plan.
Thanks so much, Valerie. In the form that you're going to, or the information you're going to get when this is sent out early next week, I have put this checklist on there so that you can check things off as they're done. I'm not going to go into it in detail because we're running out of time and want to get to your questions. But one of the things that I did want to point out is that there are a few additional things you should think about, especially right now when we could become very suddenly very ill. Do you have someone else in your home that will need care? They may be exposed to the virus as well, or they're in a situation where they have dementia or some other kind of need. Clearly indicate that and who the first responders should call. Make pre-arrangements for your pets and have those clearly indicated on your documents, and let somebody know where all your relevant account and computer passwords are. This can be something that could save months, if not more, of heartache for your family when they can't access any of your apps and banking. And finally, put all relevant documents in a clear folder or binder or green sleeve, and place these documents on or beside your fridge, or put a clear note on your fridge where these documents can be easily found. It's the universal place for your first responders and paramedics to look. And then finally, give copies of important documents to your substitute decision makers, your enduring power of attorney, and your executor, and let them know what they're for. I've run into a lot of people who have been given these documents and they've tucked them away firmly in in the back of a filing drawer, and they didn't know what they were for. So do go over this material. An advance directive is absolutely worthless if you haven't talked to the people you love. And I want to end with a final bit of the poem. If it's day 2 or day 3 and there's been no real changes, no, sorry, I've already done that one. If odds don't look good, please don't grasp at faint straws. Tell my kids, friends and mother, and my in-laws to gather and just for a moment, take pause. Tell me you love me and give me a kiss. Have them turn off the things that buzz, whirl, and hiss. Have the nurse give me meds to make sure I feel good and pull the tubes out, knowing it's understood that you were first rate in a tough situation. You have only my love and my firm affirmation and my trust you've performed as in past situations in a way that's exceeded my best expectations. So just a quick moment to thank all of our members who've sent in important information resources. We've tried to use those wherever we could. All resources and sources used in this presentation are listed in the footnotes and resources at the end of the Advanced Care Planning COVID-19 Toolkit. There's a wealth of information in there, and we hope you'll take the time to look through them and find a great new blog or a new book. If you have any additional resources that we should know about, please send them to me or to Maureen, and we will try to add them to our growing resource guide. There was a lot of information in this presentation, but it comes down to one massively important step. Talk to the people you love and those who might be making decisions for you about your values, beliefs, and your preferences for future health care. And remember, it's your life, it's your choice, but in order to have your choices met, you must clearly communicate them to your loved ones, substitute decision makers, and healthcare teams. And it's time for questions.
Thank you, Connie. I'm going to ask my colleague Kelsey Goforth to open up with the questions, and we'll start going back and forth and get through as many as we can here. And thank you to Valerie and Connie, and we'll be answering, just chime in, Valerie and Connie, as you're able to answer. Kelsey?
Yes, thank you. So the first set of questions are related, so I'm going to just ask them both at the same time. So you mentioned earlier that your substitute decision maker, or whatever that person is called in your province, can provide their input over the phone, so they don't necessarily need to be in person with the individual. So the question is, can this person be very far away? Can they be out of the country or live out of the country? And then the second piece is, if, say, I was living in another country, the US or elsewhere, and I had some sort of advanced care planning document from that country, from perhaps an organization like ours or somewhere else, could I keep that document and then use it here in Canada if I was then living in Canada?
I'm going to chime in part two. Generally, no, it doesn't work when you cross borders from another country. And I think it could be a significant amount of time if that will ever be possible. But even within the provinces, we have different documents, and all healthcare legislation says that if they have the same intent in one province, that they will be honored in another province. And as far as how far away can you be, with modern technology, and telephones, there really isn't a problem that way. Often a couple of healthcare providers will get on the phone at the same time to witness the information that's being received. Time is often the factor for those kinds of conversations. So if you're in Saudi Arabia and your mother is here, that can be an impediment. But if you're willing to answer the phone in the middle of the night, then technology has brought us to be able to do all that.
The only addition I would make to Connie's comments are just around the intent of the document. So it's not that you need to start again completely. You take the nuances and the underlying rationale of the document that you've created and wherever you lived before, and you insert it into the appropriate document for where you are living now. So I think as long as your values and beliefs, haven't changed, and the important information in the document is transferable, that it doesn't need to seem like a sort of, once you've done it, right? It's just sort of fitting it into the new box that is wherever you live now, and that their legal document requirements.
Okay, thank you. Sounds good. The next question, again, this is a bit of a two-parter. So the first part is, could you share a little bit more about what is palliative sedation and what that would look like? And then the second part is just giving us a bit more information on how home palliative care is working under our current circumstances with COVID-19. And for people who maybe, know at this point in time that they wouldn't want a ventilator, they wouldn't want, any heroic measures at end of life, they would just want to be made comfortable. How would that look for them in a home setting?
So lots of work is being done across the world, across North America, across this country, across this province, across every province to look at supporting patients with a palliative care intent, recognizing that either people are going to make this choice for themselves or it may be made for them in a surge situation where we don't have enough resources to provide intensive support for individuals, and therefore we will need to still be able to provide palliative care for them and to ensure their death is as symptom controlled as possible. So in our area in Ontario and in other areas, we've been working on creating kits of medication that would be sent home with an individual who was presumed or definitively diagnosed with COVID, who wanted to die at home, that would contain medications specific to address dyspnea or shortness of breath, which is one of the main concerns with COVID-19 patients, and anxiety, as well as all the supplies in order to initiate those medications. So there is definite work on the ground in how to support patients either choosing or by default needing to go home to die with COVID. And it should be in line with the palliative care strategies that are in place already to support patients at home. The reality is, although COVID-19 is very new, the symptoms that people are dealing with at the end of life when they're dying from COVID are very similar to many other types of or causes of death. So shortness of breath is a very common symptom that we deal with all the time with people at the end of life for a variety of diagnoses. So it makes me feel a little bit better as a palliative care practitioner that I'm not being asked to treat something I know nothing about, because I do know lots about dyspnea. It doesn't really matter how or why someone is short of breath, it matters how you manage that. And so the strategies are very similar. So it is possible to palliate somebody at home with COVID-19. Palliative sedation specifically is an intervention that we utilize in palliative care when we've tried everything else and we can't get on top of the symptoms. So it's a very specific intervention that is required when someone has what we call refractory symptom. So we can't ameliorate or palliate the symptom with our usual techniques. And so in that case, we will put someone into a coma with the understanding the goal of that sedation is to relieve suffering for that individual. Sometimes we need to sedate someone to a point where they're no longer able to converse, they're not able to take anything orally, and so they may die while in that coma, but the understanding is the goal of putting a person in a coma or decreasing their level of awareness is to ameliorate their suffering, not to cause their death. So it is very different, the medical assistance in dying, and it's used specifically when a clinician feels that they've gotten to the end of all of the tools in their toolbox and nothing is working. It is something that we use outside of the COVID realm, but we're recognizing that sometimes with patients who are dying from COVID, their symptoms can be quite intense and come on quite intensely, and often people are requiring palliative sedation more quickly than in other diagnoses.
Okay, anything to add, Connie or Maureen?
I'm good.
You're good? Okay. So this question is quite interesting. So, and this I think it can be applied to both the COVID-19 situation or other end-of-life situations as well, I imagine. But is there a risk that either your SDM or perhaps even just the person you're living with?
Oops, we lost you.
Hello, can you hear me?
Yes.
And
Now.
Okay, sorry about that. Is there any risk that your SDM or someone else in your home could be charged with negligence in the event that you died at home because you didn't want to go to the hospital? And if there's any potential repercussions for somebody who has decided to die at home?
wow, that is an interesting question. I haven't heard that come up.
Me neither.
Don't know.
I couldn't comment on that.
There haven't been very many deaths at home. There've been a few sudden deaths. So I don't think it's a huge issue.
Okay, great, thank you. And yes, no legal advice through the webinar, so some questions might be better directed at your lawyers. So, but good and very interesting question. Another question, so can your substitute decision maker be a witness for your advanced care planning documentation, or would you need somebody else to do that, to do the witnessing of it?
They cannot. No, they cannot. And they also cannot be somebody who is going to be a beneficiary to your will, to your estate. So that makes it really tricky when you're in a household. So I was doing my, I did a new power of attorney, and I live in an apartment. So I sat in the doorway of my apartment. I signed it. I walked it over to my neighbors who were 12 feet away. I scooted it over to them, and they signed it, and they scooted it back to me. So it was a little inventive on the witnessing, but no, it can't be somebody who is the substitute decision maker or will benefit from your estate.
Okay, I have a question here, and I think it's a pretty straightforward answer, but is there a file of sample anonymous advanced care plans that your organization view as well thought through documents?
We're trying to develop those with a bunch of examples. They're going to be in our new toolkits. I think that would be brilliant if somebody wanted to send along their, take their information off of it and to send them to us. We would love to use those. I think it's a brilliant idea. No, we haven't yet.
Thank you.
Okay, this question is about medical assistance in dying and how that is going during the COVID-19 pandemic, and if there are any changes to how MAID assessments are carried out, or any impacts on access to medical assistance in dying at this time.
Leave that one to you, Maureen.
I'm sorry, Kelsey, can you repeat the question? I was trying to get ahead of the questions there, so just briefly.
I'm happy to step in, Maureen, if you want.
Oh,
it's just about just about MAID assessment and provision. So
Sure.
at this point, there have been some jurisdictions across the country that have determined in their context of healthcare delivery that medical assistance in dying is not an essential service. And however, there are areas of the country who have deemed medical assistance in dying an essential service. Regardless, I think the idea is that MAID assessments and provisions will go on as long as there are assessors and providers available to do those interventions. We're trying to be a little more creative in decreasing home visits. So some assessments for MAID have always been, and now more so in this instance, being done virtually over video conferencing. The more concerning issue that's come up is in regards to witnessing. So in Ontario, we use a clinician aid, a document called Clinician Aid A that needs to be witnessed by the two independent witnesses, and obviously with people physically distancing and socially distancing, and it can't be somebody who provides care to you or who will benefit from your death, it makes it challenging. So we've found some creative ways to get around that, witnessing through a window or witnessing with an iPad over the shoulder while you watch the individual sign. And what we've been hearing from the organizations who are overseeing MAID in the different provinces is that they're being quite open and accepting of the variety of witnessing and the workarounds that we're needing to do in order to get this done. So for example, if there's 2 separate witnesses watching on 2 separate devices that this individual is signing a clinician aid A, then 3 separate versions of that form will go to the provider to be submitted with the package to the Ontario Office of the Chief Coroner. So that's really the only difference at this point. And I think Kelsey or Maureen could speak to the idea that we may be having some more opportunities for virtual witnessing through Dying with Dignity.
Yeah, I'm going to let Kelsey jump on that one.
Sure, yeah. So we will be moving forward with virtual witnessing in a few provinces across the country. And at this point, since this is a bit of an unprecedented situation and we want to make sure that our volunteers who are actively witnessing have everything that they need to be able to do this and support folks across the country, we're working through and getting some documentation and training specifically for this situation for our volunteers. But if anybody on the call is looking for witnesses, and just to be clear, this is for independent witnesses for assisted dying or MAID requests. This is different than the witnesses that we're talking about for people's advance directives for more general healthcare decisions. But if people are looking for information about assisted dying and getting witnesses for your forms, reaching out to us directly is an option. We could talk through whether or not virtual witnessing is available through Dying with Dignity Canada in your province.
Thanks, Kelsey. I have a question here from somebody who wants to know, do you have any advice for how to talk to my family about end-of-life decisions, especially during COVID-19? I'm somebody who would want MAID sometime in the future, but I don't know how to bring up the subject with my family. Any advice on that one?
Again, scripting is a really good idea to actually write it out and say, and I struggled with this when I was talking to my adult daughter, who's my representative. I didn't want to hurt her. I didn't want her to be worried about me dying. And so one of the things that I said right up front was, everything's okay. There's nothing wrong with me right now. I'm just planning for the future. Or if you do have something wrong that you would think about MAID, say, you know what, I'm pretty good right now, but it's really important that I have this conversation with you. And in our, as somebody has just put out, end-of-life doulas can help with that conversation. There's also several excellent guides, particularly through the United States. The Conversation Guide, 5 Wishes. We've got end-of-life planning and End Well, and we've put all of those in the resources on the ACP COVID-19 toolkit.
I think another suggestion that I would make is capitalizing on the frequency with which we're talking about this these days and it being in the news, and perhaps instead of making it, depending on your family and depending on who you're hoping to speak to and your relationship with them, making it not so formal, right? Something comes up on the news and you say, that sounds awful. What would you want if something like that happened to you? And just sort of bring it into a casual conversation, or I couldn't even imagine going through that. Like that for me, I don't think that's something that I would want. And sort of just enter into the conversation more in a casual way, rather than it being this big, intense thing that you have to sit down and feel like you need to get to, right? Even having a few of those little conversations to introduce something as intense as end-of-life discussions can help broach that subject matter and make it a bit more comfortable for everybody to deal with, and know that you're not alone in feeling like it's a hard conversation to have, because it is, but oftentimes the things that are hard in life are the most important, right?
Those are great answers. Thank you so much. And there is no right or wrong way to do it. It's however it comes up, and you know, whatever works for each of us. I'm going to thank our panelists so much for joining us today. This has really been a thoughtful and thought-provoking conversation. I'm going to give you a chance to do last comments as well, but I'm going to make a couple of announcements. So after this webinar, everybody who has been online will receive the Advanced Care Planning and COVID-19 Toolkit, a link to that, as well as information, the script notes from today's conversation, and a few other resources, links to those. Another note, the webinar will be available in a recorded format on our website. And if you know anybody who's looking to access it in French, it will be recorded on YouTube with closed captions. There's an option with closed captioning to have that translated into French. So we will have a French version available by the middle of next week. And these are available to anybody in the public, not just Dying with Dignity supporters. So anybody can come to the website. And I'll open it up again to Connie and Valerie. Any last words that you'd like to share with the folks who have joined us today?
I just want to say thanks everybody for taking the time to spend this hour and a half with us, and I hope you found some useful tips and tools to start having these conversations. And I wish you all to stay healthy and safe during these times.
Thank you. I just wanted to say that we're going to continue to move forward with getting the new Advanced Care Planning Toolkits done over the next few months. And all of this has been a really huge help in getting that done. And I have a lot more time at my desk right now. I want to say what a privilege it's been to work with Valerie and Maureen on this. It's been a great collaboration. And please do continue to send us your comments and your thoughts as you move forward. And do stay safe and stay apart. And hopefully we have a completely different conversation a year from now. Thank you.
And wash your hands.
Thank you both so much, and I want to give a shout out to Kelsey Goforth too, who fielded all the questions and does such a great job in managing the program and support and navigation area at Dying with Dignity. If you have questions that you think of afterwards, feel free to reach out to us at info@dyingwithdignity. Or I believe all of you have my email address, so send in your questions or concerns, and we look forward to seeing you on the next webinar. So take good care and good health to all of you. Bye-bye.
Bye-bye. Thank you.
Bye.